discussing a child with chronic liver disease. Well, so what is chronic liver disease? This is a progressive deterioration of liver functions for a period of more than 6 months, with the potential to progress to cirrhosis and end-stage liver disease, which may subsequently require even liver transplantation. This may be caused by several causes, various types of infections, autoimmune hepatitis, various drugs, and various metabolic liver disease. So these children should be followed up by the primary pediatrician with the help of the pediatric gastroenterologist, dietitian, and even the psychologist. So what is jaundice? How do you define jaundice? Jaundice is defined as an yellowish discoloration in the skin, conjunctiva, and mucosa when the serum bilirubin is more than 2 to 3 milligrams per cent. Now, the genesis of the word jaundice is quite interesting. Actually, it was derived from the French word jaunisse. Now, what separates France from England is the English Canal. So as the French word jaundice crossed the English Canal and reached England, the English people, they were not willing to accept the term as such into the English language. Maybe because of the big political rivalry between France and England in those days. And here you can see this wicked-looking Englishman with a crooked smile on his lips, inserting a D to the jaundice, to convert jaundice to jaundice. And that term is stuck and become quite popular among doctors all over the world, much to the chagrin and dismay of the French people. The French people are very angry because we don't use the word jaundice anymore. So what are the synonyms of jaundice? There are two synonyms. One is icterus, and the second one is morbus regis or royal illness. Why is it called icterus? There are two theories. One theory is that is the icterus bird, whose zoological name is Icterus baltimore. Look at the feathers of this bird. It has got beautiful yellowish orange feathers. And because of the resemblance of the feathers of the icterus bird, maybe jaundice came to be known as icterus. Another theory is that the mythology or idiom. The myth is that if a jaundice person, like this lady, stares at this innocent, the poor yellow bird, his or her jaundice would be magically transferred to the bird, to the poor bird. That is according to the Roman author Pliny. We know that this is never going to happen, but this is one of the theories why jaundice is called icterus. Now, why is it called morbus regis or royal illness? Well, the ancient Romans, they were crazy about gold, or they liked anything that looked like gold. And since jaundice being yellow resembled gold to them, they called jaundice as the royal illness or the morbus regis. But I'm really skeptical whether jaundice can truly be called the royal illness. Why? Because jaundice afflicts not only the poor and the downtrodden, and it can affect all types of people. And here you see, who are these people? Here you see Elizabeth Taylor and Richard Burton in their famous roles as Cleopatra and Mark Antony in the English classic Cleopatra. You can see that not only Cleopatra's hair, even her blouse sleeves are full of gold. That may be one reason why they call jaundice as the royal illness. Now, this case will be presented by Dr. Aisha, who is the first year MD student. So this is going to be an interactive session. Questions will be in red letters. I'll be asking questions in red letters. And if possible, you can write the answers in the chat box. Vishnu, you can check the chat box for answers. Vishnu? Hello, Vishnu?
Okay, sir. Sure, sir. Sure, sir.
So relax and enjoy the class, and all the very best. Okay, Aisha can start.
Good evening, everyone. So I'm going to present the case of a 13-year-old girl born to second-degree consanguineous parents, presented with jaundice for 1 year duration and abdominal distension for last 10 months, and vomiting of blood and passing black stools for last 3 months.
So she has written the presenting complaints in the chronological order. Jaundice of 1 year duration, followed by abdominal distension and upper GI bleed. So these were the presenting complaints of this patient. Now, what's the relevance of consanguinity in this child? In a chronic liver disease, what's the relevance of consanguinity? Can somebody answer that? What's the relevance of consanguinity? One is Wilson disease. And so many Many of these, the metabolic liver diseases are autosomal recessive. The most important, one of the most important ones is Wilson's disease.
Wilson disease.
Wilson disease. So many. What are the others? Can you mention some of the others, Aisha?
Cystic fibrosis, alpha-1 antitrypsin deficiency,
Galactosemia.
PFIC, progressive familial intrahepatic cholestasis.
So many conditions. All these, most of them are autosomal recessive.
Autosomal recessive inheritance.
And there are various methods of classifying jaundice. Depending upon the cytopathology, when the liver is damaged, it's called hepatic jaundice. Classic example is hepatitis. When there is something or some obstruction beyond the liver, that's called post-hepatic jaundice. The classic example in pediatrics is biliary atresia. And sometimes the liver is entirely normal. That is a pre-hepatic jaundice. Classic example is hemolytic jaundice. So essentially, you can also say that depending upon the type of bilirubin, we have unconjugated jaundice, which is a pre-hepatic jaundice. That is also known as echoloric jaundice. What does col mean? Col means bile. Echoloric means there is no bile in the urine. So that is echoloric jaundice. Then conjugated jaundice may be, that's called choleric jaundice. And these are two types. That is hepatic jaundice or hepatocellular jaundice. And then we have cholestatic jaundice. Okay, so these are the various types of jaundice. So what questions should you ask to know to find out the type of jaundice? And when a child is presenting to you with jaundice, what are the important questions to be asked to the patient? What is the first question? What is the first question?
Ask about the color of the urine.
Yeah, but the first question is about the color of the urine.
Color of the urine.
Suppose the mother says it is a dark yellow. That means it is a conjugated jaundice. It may be hepatitis or it may be cholestatic jaundice. So you ask the second question. What is that? What
color
is the
of the stool.
The stool is of normal color, probably that is hepatocellular.
Hepatocellular.
I hope that's clear to you. If it is pale, that is
Obstructive jaundice.
cholestatic jaundice. Now, what type of jaundice is this patient having?
She was having dark colored urine and pale colored stools.
So what type of jaundice is this?
That is cholestatic or obstructive jaundice.
Cholestatic jaundice, because this child is passing pale stools as well as high colored urine. Then that takes us to the question, what is the color of normal urine? What is the color of normal urine?
Straw colored urine.
Anything any answer in the chat box? What is the color of normal urine? Vishnu, somebody's written?
Yeah, there is an answer as amber colored by Dr. Manu Varghese,
Okay.
colorless by Dr. Fasana, straw by Ahmed Musa.
Okay. So what is this? This is the clue for that. What is it? This is straw.
Straw.
So the typical color is straw colored, as they have rightly mentioned, straw colored or amber colored. Once I asked an undergraduate student, what is straw? Then somebody said, you know the straw which we used to drink Coca-Cola. It's actually not that straw. This is the white coal or the hay. Okay. So, and then this urine is pale yellow. It's not colorless, it is pale yellow color. Why is it so? Why is it amber colored or straw colored? What gives this the particular color? Which pigment gives this particular color to the urine? Anybody? Which pigment gives urine this particular straw color or amber color? Aisha?
Urobilin.
What's the other name of urobilin?
Urobilin or the urochrome pigment.
So it's actually urochrome or urobilin which gives the urine its peculiar straw or amber color. What is the significance in acute diarrhea disease? It's very significant. Suppose you got a child with an ADD. One of the first questions, one of the most important questions you should ask is what is the color of the urine? See, you can see that as the dehydration increases, the urine will become darker in color. So dark urine is actually a bad sign in a child with diarrhea, any type of dehydration. Now, what is this? This is the normal urine, and this is the normal straw colored or amber colored urine. This is the bilirubin. This is the classic color of hepatitis. Aisha, yes.
So the child was on indigenous treatment with Kiarnelli for last 1 year, and her jaundice was waxing and waning, but has never completely disappeared.
This is very important. For the past 1 year, the child is continuing to have jaundice, which has never completely subsided. It is waxing and waning. Okay, this has to be a chronic liver disease. Yes.
And she was having abdominal distension for last 10 months.
Now, what are the three important causes of abdominal distension in children? Anybody other than Aisha? What are the three important causes of abdominal distension in children? Important causes of abdominal distension in children. Vishnu, anybody in the chat box? The three important causes of abdominal distension in children. Aisha?
Can be due to fluid accumulation, that is ascites, or it can be organomegaly, or it can be any swelling like any tumors,
Okay.
like neuroblastoma or
A
Wilms.
massive organomegaly, massive hepatosplenomegaly is one of the most important causes of abdominal distension in children. Second one, as she is rightly mentioned, is ascites. And the third one is a lump in the abdomen, a tumor like Wilms tumor, a neuroblastoma, or hepatoblastoma. These are the three important causes of abdominal distension in children. Now, what are the features of abdominal distension due to organomegaly? Suppose a child has got organomegaly, say hepatosplenomegaly. What are the features? What are the striking features of this type of abdominal distension, which is secondary to organomegaly? Where does the abdominal distension start? For example, you can see that these children, they're actually not siblings, but they've got a very striking resemblance to each other. And they've got a huge hepatomegaly, mainly affecting the upper part of the abdomen alone. So, when there's a gradual onset of upper abdominal distension spanning over several years, that is suggestive hepatomegaly with or without splenomegaly. So, an isolated hepatomegaly can cause upper abdominal distension. Okay. Now, subsequently, suppose the child develops a generalized abdominal distension, then what may be the cause of that? This child, later, after a few months or a few years, develops generalized abdominal distension, then what may be responsible for that? That may be because this hepatomegaly is progressing. For example, you can see that in this particular child, the hepatomegaly is really progressed. Or what may be the other cause? So to begin with, the child had upper abdominal distension, and then now he has developed generalized abdominal distension. It may be due to massive hepatomegaly, the liver size has increased, or it may be due to ascites because the child has developed decompensation. A child with chronic liver disease has developed decompensation and has developed ascites. This is another condition, another cause why the initial upper abdominal distension has now become a generalized abdominal distension. Hope it is clear to you. Now, what are the other causes of a generalized abdominal distension? Can you name some other cause of generalized abdominal distension? What is this?
Obesity.
Obesity. Remember, the children with obesity, they'll be having massive abdomen. So how will you differentiate this from ascites? How will you differentiate this massively distant abdomen from ascites? The point is that in severe obesity, you'll get a uniform dullness on percussion. If it percuss a child with a severe obesity, there'll be uniform dullness on percussion. You will not get the shifting dullness and other signs of ascites. So uniform dullness on percussion is 1 point. Then recall the umbilicus. What happens to the umbilicus in obesity? The umbilicus will be sunken. This is in striking contrast to ascites, where the umbilicus will be protuberant, or there may be an umbilical hernia. Another cause is the fecal mass due to severe constipation. For example, a child with Hirschsprung's disease. Can you see that this is a child with Hirschsprung's disease which has not been operated? So what will happen? You'll get a massive abdominal distension, maybe due to fecal mass, and there may be partial relief by passage of stool or by enemy. It will never completely subside. Suppose it is flatus, then you get a tympanic resonance throughout, and the distension may be relieved by the passage of flatus. I'll take you to another question, a very important question. What is pseudoascites? Heard of pseudoascites? Shana, Vishnu, anybody in the chat box? What is pseudoascites? Have you heard of pseudoascites? What is the significance of pseudoascites? No. So this is an uncommon cause of abdominal distension which may mimic ascites. And what is the cause?
Can be due to any cystic lesions like ovarian cyst or retroperitoneal, any mesenteric cyst.
That it may be due to a huge mesenteric cyst or mental cyst or cystic lymphangioma or ovarian or renal cyst. Sometimes it will be very difficult to differentiate from ascites. There may even be fluid thrill. So just as in the case of massive ascites, you may get a fluid thrill. And the CT and even MRI will fail to differentiate ascites sometimes from such huge cysts. The only method of differentiation may be by laparotomy. You can see like something like this. So this may be mistaken for massive ascites. A few cases of pseudoascites in children have been documented. So somebody may ask a short note on pseudoascites in children. Now, what are the features of abdominal distension due to splenomegaly? We have been mentioning only about hepatomegaly. Suppose a child has got abdominal distension due to splenomegaly, then how does the child present? Remember that an isolated massive splenomegaly usually does not present as a uniform abdominal distension. It presents as a lump in the abdomen, especially left upper quadrant. It presents usually as a lump and not as a generalized abdominal distension unless there is an associated hepatomegaly. So along with hepatomegaly, splenomegaly will cause generalized abdominal distension. Otherwise, it usually causes a lump in the left hypochondria. That's how you differentiate these conditions. Now, look at these children now. What could be the diagnosis? That girl in the middle, she is 10 years, and this child is 3 years, and this boy is 10 years. The girl has got abdominal distension. Can you spot the diagnosis? What may be the cause of abdominal distension? Anybody? Anybody in the chat box? Vishnu? So she's 10 years and she's almost as tall as only this.
Hypothyroidism.
This is a classic case of, yeah, that's right. This is a classic case of congenital hypothyroidism, which was missed for a very long time. We always teach you that hypothyroidism, congenital hypothyroidism is one of the most important preventable cause of mental retardation in the world. So this child too has got abdominal distension. Okay. But remember that this abdominal distension will not be the presenting complaint of such a child. These children do not come to us for abdominal distension, but they may become for global development delay, delayed passage of meconium, constipation, lethargy, poor feeding, and so on. Okay, but they will also be having abdominal distension, and they may be having jaundice also. Usually unconjugated jaundice, but remember that congenital hypothyroidism is also an important cause of cholestatic jaundice, especially in neonates. Okay, Aisha.
So she had a history of recurrent episodes of vomiting blood for last 3 months. And it was fresh blood. And it was followed by the passage of black tarry stools. And she was given blood transfusion 4 times.
So that means she had a massive bleed. Yeah, she had altered sensorium and she went.
She had also undergone OGD scopy.
Now, what is the minimum quantity of blood required to produce melena?
50 to 100 ml.
Some people say 50, and I think Harrison says it 50 to 100 ml. You can say 50 would be okay. Now, how do you classify GI bleed? Anybody? How do you classify GI bleed? Essentially, 2 types of GI bleed: upper GI bleed as well as
GI
lower
bleeding and lower GI bleeding.
Now, what is the basis of this classification?
Based on the ligament of Treats.
In relation to the ligament of Treats. When the pathology is proximal to the ligament of Treats, where is the ligament of Treats? At the junction between the duodenum and the jejunum. When the pathology is proximal to the ligament of Treats, it's called upper GI bleed, and when it is beyond the ligament of Treats, it's called
lower GI bleeding.
Okay, and upper GI bleed may present as hematemesis, melanomesis, or as melena. Lower GI bleed usually presents as hematochezia or passage of fresh blood in the stools or optic blood. Now, what are the various causes of upper GI bleed in children?
Can be.
What are the most common cause? Obviously, rupture esophageal varices is not the most common cause. What is the most common cause of upper GI bleed in children?
Can Mallory-Weiss.
In the newborn period, it's always solid
Solid
maternal
maternal
blood. We know about the solid maternal blood syndrome. In older children, Mallory-Weiss syndrome. What is Mallory-Weiss syndrome?
Due to repeated vomiting, there can be a longitudinal tear in the gastroesophageal
Sharina
junction.
Kadar is in there. Sharina Kadar should be our old PG. Is now in Trichur. Okay. Thank you, Sharina. And you have Mallory-Weiss syndrome. There is a longitudinal tear of the G junction. It may be about 2 to 4 centimeters long. Another very important cause is erosive gastritis. And nowadays, a lot of children, our patients are on various types of NSAID that can cause erosive gastritis. Then, of course, the upper GI bleed due to rupture of esophageal varices secondary to portal hypertension. Peptic ulcer disease is a very rare cause in the pediatric age group. What is Boerhaave syndrome?
A rupture of the esophagus.
The very rare
forceful vomiting.
Yeah, potential fatal complication of prolonged retching and vomiting. That's the Boerhaave syndrome. which is characterized by a through and through rupture of the esophagus. Okay. The triad of a Boerhaave syndrome is called the macular triad: vomiting, chest pain, subcutaneous emphysema. What is the osculatory sign?
There can be Hammond sign or the mediastinal crunch sign.
That's it. You may, if you are very careful, you can appreciate the Hammond sign of the mediastinal crackling sound, which is best appreciated in the left lateral decubitus position. And what are the causes of GI bleeding in chronic liver disease? Why do you get GI bleeding in chronic liver disease?
There can be rupture of the esophageal varices.
A large varices. So rupture of esophageal varices is one of the most important causes. There's no doubt about it. What are the other causes?
Congestive gastropathy.
There's a condition called congestive gastropathy. You can see the congestive gastropathy. Anything else? Duodenal ulcer. They're prone to develop duodenal ulcer. You know why? Why do they develop duodenal ulcer? Because
Due to hypergastrinemia.
gastrin is metabolized by liver.
Liver.
Damaged liver may not be able to metabolize gastrin. So there will be hypergastrinemia, and hypergastrinemia may be responsible for the increased incidence of duodenal ulcer in children or in patients with cirrhosis. What is melanomesis? I heard of this term, melanomesis. I'm sure you heard of melena. What is
vomiting of dark ground, coffee ground vomitus.
Vomiting of the coffee grounds vomitus. That is classically described as melanomesis. What is melena?
Passage of black tarry stools. Offensive, black tarry offensive stools.
Black, tarry, loose, sticky offensive stools. Okay, that is melena. Now, what's the finding in the oral cavity of this child? Anybody other than Aisha? What's the finding in the oral cavity of this child? Nujuminza from Anjarakandi Medical College. Nujuminza. What's the finding in the oral cavity of this child?
Chlorodontia.
That is chlorodontia. I can see chlorodontia. This is one of our poor patients with the Alagil syndrome who have developed chlorodontia. That means that his dentin has been exposed to very high levels of bilirubin right since his birth. So this is chlorodontia. What are the causes of recurrent epistaxis in chronic liver disease? Before that is thrombocytopenia. It may be due to thrombocytopenia due to hypersplenism, or it may be due to coagulopathy due to decompensated chronic liver disease. So coagulopathy can be there. They can thrombocytopenia due to hypersplenism. These are some of the important causes of not only epistaxis but also bleeding. Now coming to epistaxis. What are the most common cause of epistaxis in children? Anybody other than Aisha? No, anybody other than Aisha? What are the most common cause of epistaxis in children? Vishnu, anybody in the chat box? It may not be gastroenterology, but what's the most common cause of epistaxis in children?
Kirtana has answered traumatic.
Traumatic. No speaking. Probably
No.
that's what they mean. No speaking. This is one of the most important causes of epistaxis in children. Now, how do you elicit a history of epistaxis? Usually we ask, do you put your finger in your nose? No child has ever answered that I put my finger in my nose. You'll never answer. So what should you ask? Which finger did you put in your nose? Then they will promptly show you this finger. Okay. So always ask, which finger did you put in your nose? And the bleeding is from a small area called?
Little's area.
Why is it called little? Is it very small?
Notice.
How small is Little's area? Why is it called little area?
Named after James Little.
James Little. James Little was an American surgeon, and there is a very delicate plexus in that area called the Kieselbach's plexus. It's very easy to rupture this delicate plexus, and that will cause epistaxis. Example, another cause is Osler-Rendu-Weber syndrome. Heard of Osler-Rendu-Weber syndrome? Anybody in the chat box? What is Osler-Rendu-Weber syndrome? Anybody? Anjali, Kannur Medical College. What is Osler-Rendu-Weber syndrome? Aisha?
Hereditary hemorrhagic telangiectasia.
Hereditary hemorrhagic telangiectasia. Genetic condition which may cause recurrent epistaxis in children. Hereditary hemorrhagic telangiectasia. How is it inherited? It's an autosomal dominant gene. It's an autosomal dominant gene. So who was Little? Yeah, she has mentioned Little was the American surgeon who described this condition. Any other Little you know of? Anybody other than Aisha? Any other Little you know of? In pediatrics, not gastroenterology. Vishnu, anybody in the chat box? Any other Little clue? Mohammed Kunyu, the clue for you. You want a further clue? It is cerebral palsy.
Cerebral palsy. Somebody has given us
Shabila.
Shabila.
Okay, Stabila.
Shabila.
Stabila from Cambridge City Medical College. Okay, so that is William John Little. So William John Little. What did he describe? He described what type of cerebral palsy did he describe?
Spastic diplegia.
Spastic diplegia. He describes spastic diplegia. So PG should be knowing that Little's disease is actually spastic diplegia. Okay. Okay, Aisha.
There is no history of recurrent lower respiratory infection.
What are the causes of recurrent LRA in chronic liver disease? What are the causes of recurrent LRA, or which chronic liver disease can cause recurrent LRA?
Conditions like
chat
cystic fibrosis.
Vishnu, anybody in the chat box? Recurrent LRA in a child with chronic liver disease may be secondary to
Cystic fibrosis, alpha-1 antitrypsin deficiency. Many have written.
Okay, very good. Cystic fibrosis, alpha-1 antitrypsin deficiency. What is the pulmonary pathology of alpha-1 antitrypsin deficiency? That's the pan-acinar
emphysema.
emphysema. And that can also cause bronchitis. You can get bronchitis in cystic fibrosis and also in alpha-1 antitrypsin deficiency. Even to the more common lesion in alpha-1 antitrypsin deficiency, pan-acinar emphysema, you can also get bronchitis. Okay, Aisha.
She also complains of shortness of breath, which is aggravated in the erect position.
Now, what is this complication of chronic liver disease called? Anybody in the chat box? She complains of shortness of breath, which is aggravated in the erect position. She is comfortable in the supine position, which is the opposite of orthopnea. So what is this complication of chronic liver disease called? Anybody in the chat box?
Musa has written platypnea.
Okay, Musa is
Many others. Shabila, Farsana, Hiba, platypnea. They have written.
Okay, this is called the platypnea orthodeoxys syndrome. Platypnea orthodeoxys syndrome, or the POS. What the other name? More common name is
Hepatopulmonary syndrome.
it's also known as hepatopulmonary syndrome, one of the dramatic complications of chronic liver disease, hepatopulmonary syndrome. I think you should study more about hepatopulmonary syndrome. You may get a short note on hepatopulmonary syndrome. So what is platypnea? What is platypnea?
Breathing difficulty in
In the sitting or standing position, but the patient will be comfortable in the supine
position.
platypnea. So there will be central cyanosis. One of the causes of cyanosis and cirrhosis is the development of hepatopulmonary syndrome. So how will you diagnose it? This has been asked some time back. How will you diagnose hepatopulmonary syndrome? What is the best test to diagnose hepatopulmonary syndrome? Anybody in the chat box? How will you diagnose hepatopulmonary syndrome? Okay, Aisha.
Can be transthoracic echocardiography.
Contrast enhanced transthoracic echocardiography. This is one of the best methods. Of course, there's some modification, but at least you can remember it's a contrast enhanced transthoracic echocardiography. Or the treatment of hepatopulmonary syndrome.
Liver transplantation.
It's the late stage. It's a very difficult condition to treat. The only treatment option is liver
Transplantation.
Okay, Aisha.
The child also complains of recurrent abdominal pain.
So what are the causes of abdominal pain in chronic liver disease? I'm sure you've seen lots of children with chronic liver disease. Some of them do complain of abdominal pain. What are the causes of abdominal pain or recurrent abdominal pain in chronic liver disease? Yes. Vishnu, anybody in the chat box? Any answer in the chat box?
No answers have come, sir.
Okay. Aisha?
Can be cholelithiasis. Can be
They are prone to develop cholelithiasis. Cirrhosis can develop cholelithiasis. Okay, so secondary to cholelithiasis, they can be cholecystitis also. So these are some of the causes, and they can develop pancreatitis, peptic ulcer disease. We already seen that they can develop peptic ulcer disease. Why peptic ulcer disease? because the damaged liver is not
Gastremia.
able to metabolize gastrin. So hypergastrinemia can be there, that can also predispose to
Peptic
peptic ulcer disease, and hence abdominal pain in a child with chronic liver disease. Another complication is SBP. What is SBP?
Spontaneous bacterial peritonitis.
Which other condition, non-gastro condition, can also cause SBP? Quick chat box. Any other condition? Is it not gastroenterology?
Nitya, Tirthana,
Yes.
Meenu, all the nephrotic syndrome.
That's right. Nephrotic
Many,
syndrome.
many.
Nephrotic syndrome is can also cause spontaneous bacterial peritonitis. Okay, Isha?
There is no history of constipation.
What is the relevance of constipation in chronic liver disease? Suppose you've got a child with chronic. How do you correlate constipation, or how do you connect constipation in chronic liver disease? Anybody in the chat box? Chronic liver disease may be hepatitis B, it may be hepatitis C, it may be Wilson disease, so many other conditions.
Hypothyroidism.
Hypothyroidism, right? Why hypothyroidism? The clue is asthma. What is asthma?
Anti-smooth muscle antibody.
Smooth muscle antibody, which is seen in which condition?
Autoimmune
Autoimmune
hepatitis.
hepatitis. Now, can you correlate constipation? Anybody other than Aisha? Can you correlate constipation and autoimmune hepatitis? In autoimmune hepatitis, there may be other autoimmune conditions, like what? Hashimoto's disease. And Hashimoto's disease can present with hyperthyroidism as well as hypothyroidism. So constipation may be due to hypothyroidism. So that's how we correlate constipation in a child with chronic liver disease, especially if it's got autoimmune hepatitis. There may be an associated Hashimoto's disease, which can present as hypothyroidism, thereby causing constipation. Okay. Aisha?
There is a history of blood transfusion in the past.
Now, does blood transfusion cause hepatitis? No. Is it possible? Why it's difficult? Difficult because we are giving only screen blood. We are screening blood for hepatitis B as well as hepatitis C. But remember that there are so many other viruses, a lot of new viruses, hepatotropic viruses have been discovered recently. So it's still possible that some of these patients may still develop hepatitis. What is the infectivity of hepatitis B? How infective is hepatitis B? Is it very infectious?
Highly infective.
How infective is it? 1 ml of blood contains how many viral particles? Somebody other than Aisha? 1 ml of blood contains how many? Nujuminsa from Anjirakandi Medical College. 1 ml of blood contains how many viral particles? Anjali? 1 trillion viral particles. Remember, that's a highly infectious condition because 1 ml of blood contains 1 trillion viral particles. What is the infective dose of hepatitis B? Anybody? What is the infective dose of hepatitis B? Anybody in the chat box? Vishnu? What is the infective dose of hepatitis B? Vishnu, anybody in the chat box?
Musa has written 0.0, 4 zeros and 1.
Okay, 0.0001. It's a highly infective condition. It is 100 times more infective than HIV. Now, which is the most infective body fluid in hepatitis B? That is obviously
Blood.
Followed by vaginal secretion. The least infective is tear. Most infective is blood, and the least infective is tear.
Yeah.
Okay, Sha?
There is a history of EC fatigability, and there is no history of palpitation.
Well, why should we think of palpitation? Suppose there is the history of palpitation. How do you account for palpitation? Or what causes palpitation in a child with chronic liver disease? Palpitation, arrhythmias, may be caused by which disease? A condition causing chronic liver disease. Obviously, it's not hepatitis B or hepatitis C. Anybody? What the relevance is? In Wilson's disease, there can be arrhythmia. There can be arrhythmias in Wilson disease. Okay.
There is no history of arthritis.
Which condition can cause arthritis? Chronic liver disease and arthritis. How do you correlate chronic liver disease and arthritis?
In autoimmune hepatitis.
Correct is hepatitis B Wilson disease and all these conditions, there can be arthritis also. Okay.
There is no history of prolonged treatment with any hepatotoxic drugs.
Now, what are the drugs that cause chronic hepatitis? There are several drugs which can cause chronic hepatitis. You should be able to say at least a few. So anybody in the chat box, can you mention a few drugs that cause chronic hepatitis? Not acute hepatitis, but chronic hepatitis or chronic liver disease. Vishnu? No. INH. Okay, INH is one of the most important ones. Another one is nitrofurantoin. Who uses nitrofurantoin in pediatrics? Nitrofurantoin is used by pediatric surgeons for children with recurrent UTI. So it's a very useful drug for recurrent UTI. But unfortunately, it's notorious to cause chronic hepatitis also. Okay. And several other drugs which may cause chronic hepatitis. Okay, include what is dantrolene sodium?
For malignant hyperthermia.
Okay. What else in neurology? What are the other uses of dantrolene sodium in neurology? Anybody in the chat box? Dantrolene sodium? Vishnu? They're not fond of neurology. Dantrolene sodium is used in diazepam, dantrolene sodium, baclofen, all these are used in tizanidine. To reduce the spasm, spastic cerebral palsy, they are used, antispastic drugs. One of them is dantrolene sodium, which can also cause chronic liver disease. Okay, Aisha.
Now coming to the antenatal history, it is uneventful. Natal history, full term normal vaginal delivery with a birth weight of 1.9 kilogram, exclusively breastfed, no history of any neonatal jaundice.
Okay. What percent of neonates develop physiologic jaundice? What percentage of neonates, newborn babies will develop physiologic jaundice? It's a very simple question. Yeah. Quickly, in the chat box, what percentage of neonates will develop physiologic jaundice? Vishnu?
60% is there. 60. Ahmad Musa.
Anybody apart from Ahmad Musa is my student? Anybody else? Yeah, 60% of term babies. Musa, you should have said 60% of term babies and almost 80% of preterm babies develop physiologic jaundice. That's the better answer. 60% of term babies and almost 80% of preterm babies can develop physiologic jaundice. Okay.
Developmental history, it is normal. Immunization, child is fully immunized up to age.
What's the importance of immunization in Wilson disease? Or any chronic liver, not only Wilson, any chronic liver disease.
We have to give an additional hepatitis A vaccination.
All these children should be given hepatitis A vaccination also in addition to hepatitis B vaccine. Right? Because their liver is already damaged. So if they develop hepatitis A, that can be detrimental. So all these children should be given. This is one of the definite indications of hepatitis A vaccine in pediatrics. Yes.
Coming to the family history, her elder sibling had died of a similar disease 5 years back.
Yes.
General examination, the child is conscious, oriented. She was afebrile. She had pallor. Icterus was present. She had mild cyanosis. And she had grade 1 clubbing, and she had bilateral leg edema, no goiter. Her weight was 25 kg and height was 130 centimeter.
Okay. Now, where is jaundice better seen? Anybody in the chat box? Anybody apart from KMCT? Where is jaundice better seen? Is Dicky from IMCH available? Vishnu? Dicky from IMCH. She's from Mizoram. Is she there?
Upper sclera, one mention. Upper sclera.
Again, jaundice. Where is jaundice better seen?
Bulbar.
Tissues, yeah. Tissues which are rich in elastic fibers and poor in melanin. There are two aspects. The tissue should be rich in elastic fibers and should be poor in melanin. Traditionally, we have been teaching students scleral icterus. Is it correct? Actually, it is conjunctival icterus, not scleral icterus. So conjunctiva, soft palate, abdominal wall, face, undersurface of the tongue, palms and soles. I'll tell you why it is conjunctiva and not sclera. So scleral icterus versus conjunctival icterus. Who is this? Anybody? This handsome man, almost as handsome as Vishnu or Krishna Mohan or TVR. Who is this? My goodness. Who is this?
Answer given Osler. Answer given also Osler.
This is indeed
Musa.
Sir William Osler. You know, Sir William Osler is the father of modern medicine. Hippocrates is the father of medicine, whereas Sir William Osler is the father of modern medicine. You know how Sir William Osler defined jaundice? He defined jaundice as yellow tinting of skin and conjunctiva and not sclera. And if you go to the internet, you get a lot of articles on conjunctive icterus and not scleral icterus. See? And one of the latest articles was published in 2016. So it's actually conjunctive icterus, which is more appropriate and correct, and not scleral icterus. Why is it so? No. The German anatomists of 1940s made a wrong discovery that sclera are rich in elastic fibers. Now we know that they're not that rich in elastic fibers. Now, what is the blood supply of? They're actually poor in elastic fibers. What is the blood supply of sclera?
Avascular.
Sclera are actually avascular, which means that bilirubin cannot be deposited in the sclera. So bilirubin is actually deposited in the bulbar conjunctiva overlying the sclera. So the correct term is actually conjunctival icterus and not scleral icterus. Okay. Now, what is the differential diagnosis of jaundice? What are the conditions? I'll give a clue for that. You are ready for the clue? Hope you are ready for the clue. What is the differential diagnosis of jaundice? This is the clue.
Shabila has carotenemia. So many
This
persons.
is the clue. How do you correlate this? This is the rabbit. A rabbit is the greatest carrot eater in the world. So theoretically, rabbit is prone to develop carotenemia.
Carotenemia.
That's why I showed a rabbit there. Now, what is this? And what's the antioxidant present in this? What is the antioxidant present in this? What is this? This is tomato. What is the antioxidant present in tomato?
Lycopene.
Lycopene. So there's a condition which is very similar to carotenemia, which is called lycopenemia. So both carotenemia and lycopenemia may come in the differential diagnosis of jaundice. And of course, some drugs like quinacrine hydrochloride and busulfan also. Now, what is shown here?
Demonstrating edema, angle edema.
This is actually ankle edema. This should not be called pedal edema. Remember that this is actually ankle edema. This is not pedal edema. What is this?
Leg edema.
This is leg edema. The other one is ankle edema. And what is this? What does the term pedos mean? What does the term pedos mean? Vishnu Koralkara waiting room. Vishnu? 13 people waiting room. They're not able to enter. Okay, so this is the term pedos means foot. The pedal edema means edema of the dorsum of the foot. So ideally, when you say pedal edema, you should demonstrate edema or the dorsum of the foot and not or the ankle. What's the finding here in the eyes of this child? Or what are the findings?
She's having icterus.
Icterus and biter spots.
Biter spots.
Icterus and biter spots also. Can you see the biter spot? Yes, you can see the biter spots also. What's the mechanism of biter spots in chronic liver disease? Why do children with chronic liver disease develop biter spots?
Can be vitamin A deficiency.
Cholestasis, because all fat-soluble vitamins will be malabsorbed, including vitamin A. Then decompensated chronic liver disease.
Retinol binding protein.
Synthesis will be decayed. The decompensated or the damaged liver is not able to synthesize sufficient amount of the transport protein of vitamin A. The transport protein of vitamin A is retinol binding protein. Okay. Okay, there's no cataract. So you see only icterus and biter spots. If you are very careful, what can you see here? Is there any other finding here? You can see that there is a ring here. If you are very careful, you can see that there is a ring here.
Ring
So this is a cave ring.
Cave ring.
So sometimes it may be possible to demonstrate cave ring without slit lamp examination. Unfortunately or fortunately, this child had a well-defined cave ring, which could be visualized without slit lamp examination. Now, what is this? This is a much better view of cave ring. Now, how will you demonstrate cave ring? Suppose the cave ring is not visible. What is the method?
Biomicroscopy,
Okay, what is this?
slit lamp.
Slit lamp examination is also known as biomicroscopy. So this is the better method of demonstrating cave ring. One of the students in an examination told me, sir, I asked her, how do you examine, how do you demonstrate cave ring without slit lamp examination? What she said was, sir, naked man's eye examination. It's actually not naked man's eye examination, but naked eye examination, not naked man's eye examination. Okay, is cave ring pathognomonic Wilson disease? What does pathognomonic mean? Means it's seen only in Wilson disease. Is it pathognomonic Wilson disease?
No, no, can be seen in other liver diseases also.
Which liver disease? Cholestasis. Any condition with a prolonged cholestasis, you can see. Any patient with a prolonged cholestasis or even prolonged jaundice, or sometimes you can see a cave-like ring also. But cave ring is seen not only Wilson disease, but also any patient with prolonged cholestasis. Which layer of the cornea is the cave ring seen?
Decimus membrane.
Okay, what is KFD? Anybody other than Aisha? What is KFD in pediatrics? Chat box. What is KFD?
So many percent caseness for us.
KSNO. Suppose you put a hyphen after KF, you put a hyphen and then D. What is it? It's actually a tip for KF ring. To say that KF ring is in the decimus membrane. KF hyphen D means KF ring is in the decimus membrane of the cornea. Okay. So one is KFD, KSNO disease. The one with the hyphen is KF ring is in the decimus membrane. So sometimes they may ask you, what are the layers of the cornea? What are the layers of the cornea? How many layers are there?
Six layers.
Till recently, I was teaching students that there are only 5 layers. But now we should be proud of the fact that an Indian is described a new layer. What is the layer called?
Duas layer.
So epithelium, Bowman's layer, substantia propria, stroma, Duas membrane, described by Harminder Singh Dua in 2013. A very recently described layer. Then we have decimus membrane and then endothelium. So there are actually nowadays 1, 2, 3, 4, 5, 6 layers. And previously we had only 5 layers. Remember that KF ring is here in the decimus membrane. So then they may ask you, what are the indications of a slit lamp examination in pediatrics? It's a short note also they can ask you. What are the indications of slit lamp examination in children or pediatrics? What are the indications apart from KF ring?
Cataract.
Anybody in the chat box? Anybody in the chat box?
So answer cystinosis was there.
That's right. Okay. Cystinosis, scleritis, in rheumatoid arthritis, KF ring, cystine, you as rightly mentioned, cystine crystals and cystinosis. Anything else?
Retinitis pigmentosa.
RP. List nodules in which condition?
Neurofibromatosis type 1.
Post gadgets, you have to say type 1 neurofibromatosis because you don't get them in type 2. So list nodules in type 1 neurofibromatosis. Then post-embryo toxin in which condition?
Watson Alagille syndrome.
Alagille syndrome. Retinitis pigmentosa. Retinal tear can be demonstrated. So it's a very useful procedure. And sometimes it may be asked such a short note also. Glaucoma also can be diagnosed. What is Fleischer's ring? So we have been discussing Kaiser-Fleischer ring. What is Fleischer ring? Anybody in the chat box? What is Fleischer ring?
So answer is keratoconus, I think.
That's right, keratoconus. Keratoconus. So Fleischer's ring is in keratoconus. And the clinical sign of a keratoconus is Munson sign. What is deposited in Fleischer ring?
Iron deposition.
Hemosiderin. It's actually hemosiderin. What will you specifically look for in the eyes of patients with chronic kidney disease? What will you specifically look for in the eyes? So you look for jaundice, subconjunctival hemorrhage, biotoid spots, cataract, cave rings. What is this? This is subconjunctival hemorrhage.
Subconjunctival hemorrhage.
What is this?
Cataract.
Just a minute, Aisha. What? Anybody in the chat box? Can you spot the diagnosis?
Ahmad Musa, sunflower cataract.
Mohammed Musa is my student. Anybody else? So this is a clue for that. So this is sunflower cataract. Sunflower cataract. What's the synonym? Who describes sunflower cataract?
Olaf.
Well, it's also known as Olaf
Olaf.
cataract. Describe a person. Ophthalmologist called Olaf. So it's known as Olaf cataract. It was described in 1922. Olaf cataract. Does sunflower cataract affect vision? A very important question. Does sunflower cataract affect vision? Anybody in the chat box? Aisha?
No, it does not affect the vision.
That a classic cataract causes irreversible damage to the lens, and thereby that will affect vision. Whereas in the sunflower cataract is not a true cataract, as it is caused by reversible copper deposition in the lens. So it is a reversible copper deposition of the lens. It doesn't affect the vision. Does not affect vision. So it's a very interesting type of cataract with a reversible copper deposition and does not affect vision. Name the only other condition causing sunflower cataract. Perhaps there's only one more condition which can cause sunflower cataract. Anybody in the chat box? Name the only other condition which may cause sunflower cataract.
Chalcosis is the answer given by.
Right. By whom?
Name is not Infinix.
Okay, good. Very good. That is chalcosis. Chalcosis is a copper foreign body in the eye. Copper foreign body in the eye. What type of cataract is seen in galactosemia? This is a child with one of our patients with galactosemia. What type of cataract is seen in galactosemia?
Oil drop.
What that's called? Yeah, that's called an oil drop cataract. What is this finding? It's not a child, but what is this finding? Anybody? This is the clue for that. Well, in patients with decompensated chronic liver disease, cirrhosis, you get a lot of telangiectasia. You can see the telangiectasia, and these telangiectasia resemble the threads of American dollars. So this sign is called American
paper money skin.
Or the paper money skin. That's the reason why it's very difficult to fake American dollars. People say that even people from Kundangolam find it very difficult to fake American dollars because there will be threats in bizarre situations. And hence this sign of decompensated chronic liver disease is called paper money skin or the American dollar skin. What is this? What the relevance?
Thyroid swelling.
The goiter and arthritis may be seen. Hypothyroidism.
Relation with autoimmune hepatitis.
No, this is all. What is this? Palmar erythema. What are the causes of palmar erythema? Anybody other than KMCT students? What are the causes of palmar erythema? Anybody other than KMCT students? What are the causes of palmar erythema? Which physiological condition can cause palmar erythema?
Pregnancy.
Once I gave a clue for pregnancy, the only condition which is seen, only in females and caused only by males. That is a clue. And the boy answered, sir, menstruation. Anyway, that is pregnancy. Pregnancy because of hyperestrogenism that can cause palmar erythema. Any other pathologic condition? Chronic liver disease, chronic febrile AIDS, rheumatoid arthritis, leukemia. And now I'll give a clue for non-KMCT students. You ready? A bike which is not Hero Honda. Somebody recently said, sir, Harley Davidson. A bike which is not Hero Honda may cause palmar erythema. Anybody?
Kawasaki, they written.
Kawasaki, that's right. Kawasaki disease, absolutely right. That is Kawasaki disease. Kawasaki disease can cause intense palmar erythema as well as plantar erythema. That's right. So what are the nail changes of chronic liver disease? What is this? What are shown here?
White nails. White nails.
What is white nail called? Leukonychia.
Leukonychia due to hypoalbuminemia.
So there you can get leukonychia, clubbing, teres nails. Sometimes you can get cyanosis, cirrhosis. We already mentioned about cyanosis, central cyanosis occurring in cirrhosis. What is this? Anybody in the chat box? The peculiar nail change. You can see that 80% of the nail. 80% of the nail is opaque and the remaining 20% has retained the normal pink color. This is called an 80 and 20 nail. What is the other name? Terry's nail of chronic liver disease. Okay, 80% of the approximately 80% of the nail is opaque. The remaining 20% has retained the normal pink color. This is Terry's nail or 80 and 20 nail in chronic liver disease. And what is this? You can see that approximately 50% is opaque and the additional 50% has retained the normal color. This is called
Lindsay nail.
Lindsay's nail or 50 and 50 nail seen in chronic kidney disease.
Chronic kidney disease.
Lindsay's nail or 50 and 50 nail. It's also known as semilunar nail or a half and half nail. But the specific nail change of Wilson disease. Anybody in the chat box? There's a nail change which is specific to Wilson disease. What is it? Aisha?
Blue lunula.
Lunula becomes blue. Okay, blue lunula. 8% only. Remember that only in 8% of children with Wilson disease will you get a blue lunula. It's also known as azure lunula. It's also known as azure lunula. What are the other causes of blue lunula? Can somebody mention the other cause of blue lunula? Drugs. Like minocycline, prolonged use of minocycline and zirobudin. Zirobudin used in HIV can also cause blue lunula, also known as azure lunula. What is this nail finding? Anybody in the chat box? This may be seen, a clue is that this may be seen in nephrotic syndrome. So this nail change is seen in hypoalbuminemia of any cause. What is it called? What is the nail change of severe hypoalbuminemia? What is the nail change of severe hypoalbuminemia? Muir-Case
line.
Muir-Case lines. One or more transverse bands across the nail is scarlet lunula. Muir-Case line. So here you can see spider nevus. Are spider nevi common in children with chronic liver? Are spider nevi seen in children with chronic liver disease? Remember that spider nevi are extremely rare in the pediatric age group. It's mainly seen in alcoholic liver disease, but sometimes it may be seen in autoimmune hepatitis. So this is how a spider nevus looks like. It may be seen in autoimmune hepatitis, but the other is more commonly seen not in pediatric age group, but with adults with alcoholic liver disease. Okay, Aisha.
Head to foot examination, skin. There is no rash, petike, purpura, or spider nevi. Scratch marks were present. On examination of chest was normal. External genitalia appeared normal. Limbs and spine was normal.
What do you look for in the joints? Sometimes there may be features of rickets.
For the wrist widening.
Yeah, you look for features of rickets. What are the mechanisms of rickets in chronic liver disease? Why do you get chronic rickets in chronic liver disease? Called hepatic rickets.
The fat-soluble vitamin deficiency will be there.
The first reason is that children with chronic liver disease are so sick that they do not go out and play, so they're not exposed to the sun. That should be the first answer. So poor exposure to sunlight. Then deficiency of bile salts. Defective hydroxylation 25-hydroxycholecalciferol. Okay, that's the function of the liver to hydroxylate 25-hydroxycholecalciferol to 125-dihydroxycholecalciferol. This doesn't take properly. The child's diet may be poor in vitamin D, and the steatorrhea will retard absorption of vitamin D. So there are so many reasons why they develop rickets in chronic liver disease. Okay, Aisha.
To the vitals, her heart rate was 60 beats per minute, regular in rhythm.
So anything funny, anything unusual about it? The child whose heart rate is 60 per minute.
On the lower side.
Yeah. What are the causes of relative bradycardia in chronic liver? What may be the cause of relative bradycardia in this child with chronic liver disease? Anybody other than Aisha? We had shown an earlier clue also. Relative bradycardia in chronic liver disease. What may be the cause? What may be the cause? Yeah, Aisha?
She was having history of upper GI bleeding. So most probably she will be on propranolol.
So propranolol therapy is one of the most important causes. Okay. The other one is cholestatic liver disease, cholestatic jaundice, cholestatic liver disease, bile acids, the old theory.
The SA node.
Maybe depressing the SA node. Okay. This child was actually on propranolol. Okay.
Her respiratory rate was 30 per minute, BP was 90/60, and temperature was normal.
Okay.
Coming to the systemic examination of GIT. On inspection, her abdomen is distended, flanks are bulging, umbilicus is pushed down and slit-like. She had dilated anterior abdominal wall veins with flow away from the umbilicus.
Now, what are the findings in this child? Anybody in the chat box? Can you quickly spot the findings in this child? What could be the diagnosis here? This is obviously not our patient, old patient, another patient with an entirely different diagnosis. What are the findings? Well, you can see a scar here, okay? And you can see a lot of dilated anti-abdominal veins. What else? The umbilical hernia, so there is ascites, okay? So this is portal hypertension. Now, what type of portal hypertension is this? Anybody other than Aisha and the KMCP students? What type of portal hypertension is this? This child has got biliary atresia, post-Kasai, cirrhosis, portal hypertension. What type of portal hypertension? Is it extrahepatic or intrahepatic? Or do you get veins in extrahepatic or intrahepatic portal hypertension? Sometimes the students find it very difficult to appreciate. So I'll take some time to discuss the fact that you get veins, anti-abdominal wall veins only in intrahepatic portal hypertension, that is following cirrhosis. Okay, so here is the portal vein, which is found by the union of the splenic vein and the supramesenteric vein. It's about 10 centimeters long. There's two parts, the extrahepatic part, which is long, and the intrahepatic part. The intrahepatic part of portal vein divides into the right branch and the left branch. Is it clear? And the umbilical vein, the pro-patent umbilical vein actually joins the left branch of the portal vein. Hope it is clear to you. Now, what is the mechanism of dilated? We are coming back to the mechanism of dilated anti-abdominal veins. In cirrhosis, what happens? You can see that these are the sinusoids. You can see the portal vein is emptying into the sinusoids. And in cirrhosis, there will be collagen tissues and fibrous tissue in the sinusoids. The sinusoids will be obstructed. Once the sinusoids are obstructed, what will happen? The proximal pressure will increase. So the portal venous pressure is increasing. So this pressure will be transmitted to the large intrahepatic portal veins also. So what will be the aftermath effect? Blood will start flowing from the left branch of the portal vein through the pro-patent umbilical vein towards the umbilicus. And from the umbilicus, it will go to the collateral vessels which are around the umbilicus, resulting in dilated anti-abdominal wall veins. Okay. So when the sinusoidal pressure increases in cirrhosis, portal venous pressure also increases. Blood starts flowing through the umbilical vein to the paraumbilical veins, thereby resulting in large anti-abdominal wall veins, which are flowing away from the umbilicus. So you get such veins only in intrahepatic portal hypertension. Okay. Now, why not in extrahepatic portal hypertension? I will discuss that also. So this is a patient with extrahepatic portal hypertension. Can you see this? Splenic vein, supramesenteric vein. The splenic vein has been obstructed maybe by a thrombus. So what has happened with the blood flow into the liver? The blood flow is actually decreased into the liver because the extrahepatic portal vein is completely obstructed. So in extrahepatic portal hypertension, there is no question of blood flowing through the umbilical vein into the anti-abdominal wall. And hence, you cannot get dilated anti-abdominal wall veins in extrahepatic portal hypertension. I hope that is clear to you. So you get veins only in intrahepatic portal hypertension, secondary to cirrhosis. Now, Kijaga was destined to be killed by whom? You know, Kijaga Vadam, Mahabharata, we have Kijaga. Who killed Kijaga? Anybody in the chat box? Who killed Kijaga? Mahabharata, nobody reads Mahabharata nowadays. Aisha, who killed Kijaga?
Demon.
So Kijaga was destined to be killed by whom? So if Kijaga has been killed, Beam is responsible. Similarly, if there are dilated anti-abdominal wall veins, then the pathology is within the liver. It is intrahepatic portal hypertension and not extrahepatic portal hypertension. Okay, Aisha?
On palpation, liver was palpable 1 centimeter below the right costal margin, firm in consistency with sharp borders and non-tender. Upper border is palpated at the 8th right intercostal space in the mid-clavicular line, and the liver span was 5 centimeter, and the left lobe was palpable 6 centimeter below the Zipfi sternum.
You can see that the right lobe is actually shrunken. Okay, left lobe is comparatively larger also. Spleen is palpable 5 centimeters, and there is shifting dullness.
Dullness was present.
So these are the findings on examination. Now, how will you palpate liver? This may be an OSCE, especially for DNB students. How will you palpate the liver? What are the steps in palpating the liver? The first step is in getting the permission of the child. Always get the permission of the child. Never examine the child without, never start palpating without the child's permission. So permission. Second one, what is the second step? Second step is
Build a rapport.
Rapport. You can see some toffee, some lollipop, something like that. So always carry sweets to the examination hall. You have to sanitize yourself. Then always stand on the right side of the patient. Make sure that you are standing always on the right side of the patient. Warm your hands before you touch the patient. Start from the right iliac fossa. Why right iliac fossa? Sometimes there may be huge liver, and the lower part of the liver may be in the right iliac fossa. If you start from the hypochondria, you may miss a huge liver. So always start from the right iliac fossa. Ask the patient to breathe in and out through the mouth. Okay. So gently move up to the right upper quadrant, lateral to move up to the right upper quadrant, lateral to the rectus muscle. So during inspiration, you keep your hands still. So as the patient is inspiring, you wait for the liver to come and meet your fingers. When the child is inspiring, you keep your hand still. Don't move your hand. But when the child is expiring, taking expiration, you move your hand up by 1 to 2 centimeters. This is the best method of palpating the liver. If the liver is enlarged, the liver will come down to meet your fingertips. You don't have to go up to meet the liver. The liver will come down and meet your fingertips. Then you find the lower edge of the liver. Then what will you do next? How will you mark the lower edge of the liver? You should never use pen. Always mark with chalk. Suppose you mark with your pen. You say that the liver is palpable 2 centimeters below the right costal margin. In fact, the liver may be 10 centimeters below the right costal margin. So what will happen? You will not only fail yourself, but also your friend who is coming next, because he believes that the liver is palpable only 2 centimeters. So always use a chalk to mark the liver, and remember to wipe it off when you leave the patient. Don't forget to rub it off. Otherwise, what will happen? You will not only fail yourself, but also your friend who comes next. So always carry chalk to the examination hall. Never draw on somebody's abdomen with your pen. Now, how do you find out the span of the liver? Draw the midclavicular. I am disappointed that many students do not draw the midclavicular line. But you say that the liver is palpable below the midclavicular line without drawing the midclavicular line. So always find out the midclavicular. You draw the midclavicular line, identify the angle of Louis, start percussing till you get dullness. Then you mark it with the chalk. Then confirm that it is a liver by tidal percussion. Mark the area between the two markings. That is the span of the liver. Okay, so that is how you find out the span of the liver. Now, many a time you find that there is a disproportionate enlargement of the left lobe of the liver in cirrhosis. Have you noticed that? So the right lobe may be shrunken, but the left lobe may be enlarged. What is the mechanism? Why is there a disproportionate enlargement of the left lobe in cirrhosis? This also requires some amount of explanation. So coming back to anatomy, the superior mesenteric vein carries nutrients from the gut, and this blood is supplied mainly to the right lobe. Okay. Now, what does the splenic vein do? Splenic vein carries hepatotrophic factors from the pancreas. This is the splenic vein. Here is the pancreas somewhere here. So the splenic vein carries hepatotrophic factors from the pancreas. And normally the splenic vein supplies blood equally to both lobes. So the splenic vein supplies hepatotrophic factors containing blood to both right lobe and the left lobe equally. That is what happens normally. But in cirrhosis, what happens is that there is a redistribution of blood supply in such a manner that the hepatic, because the hepatic architecture is completely altered by fibrosis and cirrhosis. So blood from the splenic vein with its hepatotrophic factors is mainly supplied to the left lobe only. It is not supplied to the right lobe. So what happens? The left lobe will undergo hypertrophy because it contains a lot of, it gets a lot of hypertrophic factors. On the other hand, the right lobe doesn't get hypertrophic factors because it is derived of the blood supply by the splenic vein, and hence it undergoes atrophy. So this is one of the reasons why there is a disproportionate enlargement of the left lobe compared to the right lobe in a patient with cirrhosis. Hope that is clear to you. What are the causes of massive splenomegaly? What disorders cause a massive, sometimes an isolated splenomegaly or a splenohepatomegaly? What are the causes, Aisha?
Extrahepatic portal hypertension.
TSS, that is tropical
Splenomegaly syndrome.
chronic malaria. Don't say just
Oral
malaria, only
diseases,
chronic
EML.
malaria. Kalaza, which is common in North India, chronic myeloid leukemia, various types of steroid disorder. These are some of the causes of massive splenomegaly. It may be associated with a minimal hepatomegaly also. Now, what are the signs of ascites? One is flank dullness,
Flank dullness,
horseshoe
horseshoe
dullness,
dullness,
shifting dullness, fluid thrill, and puddle sign.
puddle
These are
sign.
classic signs of flank of ascites. Okay. So, Aisha, you can continue.
On examination, shifting dullness was present. On auscultation, normal bowel sounds heard. There is no bruit, venous hum, or friction rub.
Now, what is horseshoe dullness? We have mentioned horseshoe dullness. Anybody heard of horseshoe dullness? I think this also requires some amount of explanation. What is horseshoe dullness? In a patient with moderate amount of ascites, you can see that the fluid is confined to the dependent areas. So what are the dependent areas when the patient is in the supine position? The flanks and the hypogastrium.
Hypogastrium.
Okay? So the fluid will accumulate in the flanks and the hypogastrium, which will be dull to percussion. What will happen to the epigastrium and umbilical area? These will be tympanitic. Why? Because of floating bowels. Bowels which contain gas will be floating in the epigastric area and the periumbilical area. So these areas will be tympanitic on percussion. Thus, you get a horseshoe-shaped area of dullness with a concave upper border due to dull flanks and dull hypogastrium. This type of dullness is called horseshoe dullness, okay, which is usually seen in moderate ascites. Now, how do you grade ascites? Anybody? How do you grade ascites? Suppose you do get ascites in the patient. The examiner may ask you to grade it. How do you grade ascites? This is the grading of ascites. Mild,
Moderate and massive ascites.
mild detected only by USG or puddle sign. Moderate by shifting dullness, horseshoe dullness, no fluid thrill. But the grade 3 is a severe or massive ascites in which there may be fluid thrill and the patient will be having
Respiratory distress.
Okay, we just mentioned puddle sign. Who was Dr. Puddle? Anybody other than KMCT students? Was Dr. Puddle who described puddle sign? Vishnu, anybody in the chat box? Was Dr. Puddle who described puddle sign? Well, puddle is not a doctor. It's just a collection of water when there is a sharp shower. After the following sharp shower, there is some collection of water. This is called puddle sign. This would describe a person called Lawson. So it's known as Lawson sign.
Lawson sign.
A very difficult sign to describe, to demonstrate. They never attempt puddle sign in the examination. Very difficult and very tiresome for the child. Okay, what is important to auscultate in the abdomen of this child? You can see a finding there. What will you hear if you auscultate here?
Murmur. Crowelier-Baumgarten murmur.
You hear a continuous murmur between the umbilicus and the lower sternum. This is called the Crowelier-Baumgarten murmur, suggestive portal hypertension, intrahepatic portal, which we already discussed. So this is a definite sign of intrahepatic portal hypertension. The Crowelier students, especially the undergraduate students, are very fond of this sign. Crowelier-Baumgarten murmur sign. Now, how will you determine the direction of blood flow in a vein? What is the sign called?
Harvey sign.
Called Harvey's sign. Okay. You identify a vein that is free of branches for a distance of 3 centimeters like this. Place and press 2 fingers close together over the middle of the vein. Both fingers are moved in the opposite direction. They're milking and emptying the vein. This results in complete emptying of the vein. Okay. Then what will happen? Finally, one of the fingers is released.
One finger.
The speed or the filling of the vein in one direction can be observed. So it's actually very easy to find out direction of blood flow. Aisha?
Examination of cardiovascular system. First and second heart sounds heard. no murmur. Respiratory system, air entry is bilaterally equal. There is no added sounds. Nervous system, she is well oriented. There is no neurological deficits.
Or the typical tremor of Wilson disease. Neurology. This is neurology. Tremor of Wilson. Wilson disease got a peculiar tremor. What is it called?
Wing
beating tremor. That's called a peculiar tremor called wing beating tremor. So summary.
Summary. She's a 13-year-old girl born to consanguineous parents with prolonged jaundice, upper GI bleed, firm hepatosplenomegaly, moderate ascites, and bilateral case of leisure ring. So bilateral case of leisure ring. We could see this even with a still time examination. Okay. So what the diagnosis? A case of decompensated chronic liver disease, that is cirrhosis with portal hypertension, and it can be most probably due to Wilson's disease. From clinical itself, we can say that this is likely to be Wilson disease because there is no other condition which can cause such a picture with KF ring. If you are sure that this is a KF ring. So what are the points in favor of Wilson disease? Why do you say it's Wilson disease? First of all, the consanguinity. She was born to consanguineous parents, and it is an Wilson's disease. It is an autosomal recessive condition. And another point is there is a history of death of her sibling due to similar illness. And on examination, she had a KF ring, bilateral KF ring was present, and she was having hepatosplenomegaly and symptoms of upper GI bleeding and ascites. And also, it was a long history. It was history was around more than 1 year long history was there. So this is likely to be Wilson disease. What are the differential diagnoses? Suppose there is no necessity for a differential diagnosis. Suppose the examiner does want a differential diagnosis. What are the other conditions which can present like this? Can be other cause of chronic liver disease like chronic hepatitis B. Hepatitis B, hepatitis C. Never forget about autoimmune hepatitis. Sometimes it will be extremely difficult to differentiate Wilson disease from autoimmune hepatitis. Okay. Never forget about drug-induced liver disease. Even the indigenous medicines, Ayurvedic medicines, etc. They are notorious to cause disease. DIL, it's not DILI or DIL. Drug-induced liver disease, drug-induced liver illness. And then the conditions like chronic bacterial syndrome can also present with a very similar picture. Which genetic diseases can present like this, apart from Wilson disease? Lot of conditions. Fibrosis, alpha-1 antitrypsin deficiency. It's actually a very rare condition in India, alpha-1 antitrypsin deficiency. Perhaps the only GST which can present with cirrhosis is type 4 or Anderson's disease. Bacteremia, etc. The presentation will be actually different. It doesn't presence is so late as in this patient. Okay. So how will you investigate this child? You can start with CBC. Complete blood count, peripheral smear, liver function test, PT-INR, serum ceruloplasmin, and slit lamp examination. And we can do the 24-hour urine copper estimation and liver biopsy, viral and autoimmune markers to rule out autoimmune hepatitis, ultrasound abdomen, and paracentesis of the ascitic fluid and calculating the serum ascitic albumin gradient. Her investigations showed her hemoglobin content was 9 gram percentage. And this was the peripheral smear finding. Anybody in the chat box? This is the peripheral smear finding of that particular patient with Wilson disease. What are the findings? You can see that there are microspherocytes. The Wilson disease is one condition wherein you may get microspherocytes. Okay. Another point is that there's a normoblast here. So there is any child with unexplained hemolysis, you have to rule out Wilson disease, especially an older child with unexplained hemolysis, Coombs negative hemolysis, think of Wilson disease. You can see here, normoblast here, you can see multiple or several microspherocytes also here. Okay. Her platelet count was 50,000. Total bilirubin was 15.5 and conjugated bilirubin was 10. Her AST was 340 and ALT was 280. And alkaline phosphatase was 30. One condition where the alkaline phosphatase is very low is Wilson disease. You can find out the cause later. And usually AST will be more than ALT. Why is it so? Because AST is in the mitochondria. Okay. And in Wilson's disease,
the brunt of damage is on the mitochondria. So when the mitochondria are damaged, more of AST will be released compared to ALT. Albumin is very low, 2.2 gram per cent, globally is high, and the prothrombin time is more than 100. That means this patient is called fulminant hepatic failure. What is the treatment for this child? Anybody? What is the treatment for what is the correct treatment for this child? Anybody other than Aisha? What is the correct treatment for this child? Is it anybody?
Liver transplant mentioned there.
Absolutely.
Vasana,
This child has to be given liver transplantation and not usual drugs. So viral markers are negative, autoimmune markers negative, cellular is very low, less than 5 milligram per cent, 24-hour urine copper was high, SAG, okay. Split diagram examination again confirmed the presence of bilateral KF3. 24-hour copper reflects serum, is a reflection of the serum free copper. Normal serum copper, free copper is less than 40, urine copper is less than 40, and Wilson disease will be very high, more than 100 per day. Now we'll have some revision questions. Vishnu, time and any, just let me know when you want to stop.
Sir, time sir. We have still 150 in the audience.
Okay, what is the most important clue for diagnosis of jaundice? Not only jaundice, any condition. The most important clue for a diagnosis of jaundice or any disease is suspicion. Just like this famous Alfred Hitchcock thriller, Suspicion, starring Cary Grant and John Fontaine. Suspicion is very important. You should not have a tube vision. You should think of the various conditions. Just don't think that this is hepatitis B or Wilson disease or something. It may not be Wilson disease. So you should suspect and rule out other conditions. So suspicion is very important. Now, how do you approach a child with jaundice? What is the first step? What is the first step in jaundice or any disease? History taking. History taking is extremely important. I am very fond of this slide because the second and third are also history. Doesn't mean that you should write history 3 times. I was just trying to underscore the importance of taking a proper history. If you take a proper history, you can have a diagnosis in 80%. 80% diagnosis can be made by history alone. Remember, the whopping 80% can be diagnosed simply by taking proper, a very good detailed history. Then you examine the child. 15% only by examination, and investigation just 5%. So the most important aspect, not only jaundice, any disease, as postgraduates in pediatrics or postgraduates in any branch of medicine, I would request you to take a proper history. If you do not take a proper history, I'm sure that you'll miss the diagnosis. So pediatrician, not only pediatricians, but all doctors should definitely be like Sherlock Holmes. You should be inquisitive like Sherlock Holmes. Now, what are the shades of jaundice? Rubin jaundice. Heard of Rubin jaundice? What is Rubin jaundice? The reddish tinge in hepatitis. Reddish shade in hepatitis is called Rubin jaundice. Flavin jaundice, the yellowish lemon yellow tinge of hemolytic jaundice is called flavin jaundice. Okay, it resembles the lemon colored lemon yellow in hemolytic jaundice. And finally, we have Verdin jaundice. What is Verdin jaundice? Verdin means green.
Greenish tinge.
It's a greenish tinge in cholestatic jaundice. We have already seen this particular patient. This is chlorodon in a child with Alagil syndrome. Clearly, ictus, I think we already discussed that. Okay, so we'll not. What is Hy's law? It's a very important law for pediatricians also. Hyman Zimmerman, the famous clinical hepatologist, said once mentioned that suppose a patient is on hepatitis drugs like ATT, and the ALT, that is the CPT, is 3 times above normal with jaundice. Then, due to drug toxicity, this has a very high mortality of almost 10 to 50%. So you should be very careful when you put a patient on hepatitis drug. You have to monitor transaminases and bilirubin. Otherwise, the mortality could be very high. On which chromosome is the gene of cellular plasmin located?
Long arm of chromosome number 3.
The age of this child is 13. Does it ring a bell? The age of the child is 13. Is there any connection between her age and her disease? What is the unlucky number? What is the unlucky disease? Remember that the gene of Wilson disease on the long arm of the 13th chromosome. So it has been, its nickname is the unlucky disease. And unfortunately, the child's age is also 13. But where is the gene of cellular plasmin? Anybody?
Long arm of chromosome number 3.
It's not on the 13th chromosome, but on the long arm of the 3rd chromosome. Wilson disease on the 13th chromosome, metalothalia is on the 16th chromosome. Okay. What's the experimental animal model of Wilson disease? Anybody other than Aisha? What's the experimental animal model of Wilson disease? Vishnu, anybody in the chat box has written it? Musa, what is the experimental animal of Wilson disease? Aisha?
LEC rat.
Yeah, that's it. This is a long event cinnamon rat. This is the experimental model or experimental animal of Wilson disease. What is the staging system of Wilson disease? Anybody? Shabila? Anjali? Aisha?
D staging system.
D staging system. Staging system is called the D staging system.
Staging system.
Now, how do you differentiate KF-ring in Wilson disease from pseudo KF-ring seen in cholestatic liver disease? So these are some of the features. Okay. Layer of cornea is different. The nature of ring is usually complete in KF-ring, incomplete in pseudo KF-ring. The color is different. And pseudo KF-ring is related to the serum bilirubin level. Okay. How does zinc act in Wilson disease?
The zinc, it can induce the metallothionein, and thereby it can trap the copper within the enterocytes.
That's right. Okay. Thus, it prevents copper from entering the portal circulation. It is lost in the stool because the enterocytes are shed in the stool. Remember that the body secretions like saliva, gastric juice, bile, etc. also contain a lot of copper. This copper will also be lost in the stool with the help of zinc. So zinc is a very useful drug. What are the advantages of zinc over D-penicillamine?
First of all, it is easily available and very cheap. And the adverse effects are also very less compared to D-penicillamine.
It is not teratogenic. It is safe in pregnancy. Suppressive. Remember that the pregnancy is very difficult to give. The other drugs like D-penicillamine, but this is very safe. It's not teratogenic. And as Aisha rightly mentioned, this is very cheap also. No serious adverse effects. Freely available. What the drug of choice in neuro-Wilson disease?
Ammonium tetrathiomolybdate.
Ammonium tetrathiomolybdate. Unfortunately, it is still not available. Okay, this is a very useful drug in neuro-Wilson disease. If we start D-penicillamine, sometimes it may aggravate the hepatic. It may accelerate hepatic failure also. Unfortunately, ammonium tetrathiomolybdate is still not available in the market. What is melanomesis? I think we already mentioned that. Coffee grounds vomiting is also known as melanomesis. A child, this is for students other than Aisha. A child with splenomegaly due to portal hypertension presented to your or is admitted to your emergency with massive upper GI bleed. Okay, with massive upper GI bleed. And you are surprised because the spleen is now palpable now. So here a documented splenomegaly after a massive upper GI bleed, spleen is not palpable. What is this condition called? Anybody? Anybody? What is this condition called? Aisha?
Smith already chat box reported.
Okay.
Smith
What is it written?
Smith Howard.
Very good. Ella, who has written it?
That Farsana.
Farsan. Very good. This is called Smith-Howard syndrome. Smith-Howard syndrome. Okay. May cause diagnostic confusion because you may not. Sometimes you may feel that this is not portal hypertension. This is only a temporary condition. Now, this is liver biopsy finding of a child with chronic liver disease. Can you explain or can you describe the liver biopsy finding and the diagnosis? Or can somebody say the diagnosis at least? What's the diagnosis? Apart from Aisha? Yes. Chat box anybody's written the chat box? Shahnawaz?
Musa, Anjali, Alpha and pass positive.
Yeah,
Alpha and
correct. Absolutely. Very good. So this is indeed, this is the description. Pass positive, dietary resistant, magenta colored, globular inclusion within the cisternae of the endoplasmic reticulum of periportal hypertension. This is a very popular, very favorite question of Noel Sara. Noel Sara is one of the best pediatric teachers, one of the best clinicians I have ever come across. And he always used to ask this particular question in PG examination. What is the liver biopsy finding of alpha-1 antitrypsin deficiency? Oh, this is, we already discussed, this is Terry snail, okay. Can the mother on a deep enzyme breastfeed? It will be difficult because that drug is excreted in the breast milk and might harm the infant. What's the mechanism of a lung injury in alpha-1 antitrypsin deficiency? Actually, this is actually a misnomer because alpha-1 antitrypsin does not have much antitrypsin activity. What does it inhibit? It inhibits elastase, which is the very toxic enzyme. And the elastase is responsible for destroying tissue, especially lung tissues, thereby causing pulmonary panacea emphysema. So in its deficiency, these enzymes accumulate and damage the liver, resulting in panacea emphysema. So this is actually a misnomer because it's not an alpha, this does not have much of antitrypsin action. It has got anti-elastase action. What's the mechanism of liver injury in alpha-1 antitrypsin deficiency? It's a tricky question.
It is the abnormal alpha-1 antitrypsin. It can get trapped in the hepatocytes and it in turn will damage the hepatocytes.
Absolutely, very good answer. Yeah, you know that the alpha-1 antitrypsin, which is abnormal, is trapped within hepatocytes, cannot be transferred out of the hepatocytes. So that will subsequently result in damage to the liver, resulting in cirrhosis. I think we'll skip some of the slides. What are the causes of unexpected elevation of transaminases? Sometimes we do come across children with an unexpected elevation of transaminases. You do investigation and find out that the transaminases are found to be elevated. So what may be the causes? Obesity. Never forget about obesity. See, these children, we are already 40 years. Very nice comment on these children. Somebody's comment. Okay, obesity, diabetes, non-alcoholic steatohepatitis, asymptomatic hepatitis B, C, Wilson disease, alpha-1 antitrypsin disease, all these conditions, there may be unexpected elevation of transaminases. What are the causes of low ceruloplasmin? Is it pathognomonic of is it pathognomonic of Wilson disease? Remember that in a normal neonate, the ceruloplasmin will be low. Kozhikode, it's the plasma protein. In Kozhikode, serum albumin is low. Similarly, serum ceruloplasmin may also be low. Nephrotic syndrome is another condition, protein leucine enteropathy. So these are some of the other causes of low ceruloplasmin, Menkes, kinky hair disease, etc. You know that copper metabolism, 1 milligram of copper reaches our gut daily. 0.5 milligram is lost in the stool. 0.3 milligram is lost in the sweat. 0.2 milligram is going on accumulating in the liver, okay, because it cannot be transported out of the liver. And that is responsible for all the damage. What are the cause of sudden death in Wilson disease? Unexplained death in Wilson disease. What may be the cause? Aisha?
Cardiac arrhythmias.
Cardiac, remember that unexplained cardiac arrhythmia. The cardiomyopathy too has been well documented in Wilson disease. What are the relevance of this animal in Wilson disease? What is this animal?
Case of giant panda appearance and MRI.
Yeah, that's it. Giant panda appearance in neuro-Wilson disease. Giant panda appearance in neuro-Wilson disease. Now, what is this MRI? This is not Wilson disease. What the MRI finding? This neurology again.
Eye of tiger.
Which condition?
Halloward-Spatz disease.
Endothenate kinase deficiency, also known as Halloward-Spatz disease. Remember that this has nothing got to do with Wilson disease. So unlucky disease, unlucky children because they cannot eat chocolates. We'll skip some of the slides. Recent advances in Wilson disease. What are the Wilson disease mimics?
Congenital aceruloplasma.
I think we will skip some of the slides then. Okay. Well, it will be very rewarding to treat or reason what are Wilson disease mimics. Head of Mednick syndrome. Mednick syndrome. These are some of the Wilson disease mimics. Okay, congenital erythrocytoplasminemia. Mednick syndrome, I think it is given in Nelson. Mental retardation, is it in Nelson, Aisha? Mental retardation, enteropathy, deafness, neuropathy, ichthyosis, and keratoderma. So it's a rare multisystem disorder of copper metabolism with features of both Wilson disease and Menkes-Kingi disease. Treatment is with zinganon. You can skip some of the slides. Now, it's very rewarding to treat children with Wilson disease. You can see that this is one of my old patients. I diagnosed this condition in 1997 when she was just 12 years old. At 17 years, she was looking like this. And at 22 years, she came to me with a beautiful gift. That is a beautiful child. Okay, that was in 2006. Then she came to me again in 2013 with another child. You can see that the first child is now almost as tall as, she's almost 8 years now. And this is the latest picture. She is now 33 years and the child is now almost 13 or 14 years. So it's really rewarding to treat children with, diagnose and treat children with Wilson disease. So finally, there are two questions to be asked to the jaundice patient. What is the first question?
Color of the
urine. If the urine is of normal color like this, it is unconjugated jaundice. You investigate the patient for hemolytic disease. The mother says the urine is high colored like this. It is a conjugated jaundice. It may be cholestatic jaundice or it may be hepatocellular jaundice. So you ask the second question, that is what is the color of the stool? The stool is of normal color. Probably this patient is causing a hepatocellular jaundice. You investigate him for a hepatocellular disorder, viral hepatitis, drugs, metabolic liver disease, etc. The mother says the stool is pale like this. You think of cholestatic jaundice and do the relevant investigations. Now, how should pediatrician tackle suspected Wilson disease? Please take this in a lighter way. Don't take it very seriously. Okay, this is the last one. We should be very careful. We should be very energetic when treating children with Wilson disease. We should be very careful, like this. Now, European pediatricians are more active and more vigorous, like this. Who are the most vigorous or virulent people in the world now? The Americans. Let's see how American pediatricians tackle Wilson disease. Extremely vigorous. Okay, it may not be so vigorous, but what do we do? How do we tackle Wilson disease, or how we used to tackle Wilson disease in the past? Nowadays, we are all familiar with Wilson disease and we are diagnosed with Wilson disease in time. But in the past, how we used to tackle Wilson disease? So we never used to think of Wilson disease. We used to give them heliotherapy or non-specific drugs like Lev-52. So it was never diagnosed and the patient used to die of his own without a proper diagnosis. This should never happen. Thank you so much for listening to me.
Thank you, Aisha and Rajesh sir, for being with us today. We have a lot of very senior faculty members, legendary teachers from the fraternity of IAP, Kerala, Purushothaman sir and Dali ma'am with us. Sir, for your comments, sir. Please unmute, sir. Please unmute, sir. Purushothaman sir, please unmute.
Will you close that slides?
Okay.
Aisha. Thank you, Ria sir, for the wonderful class.
Thank you, Purushothaman. Thank you.
Yes, as always. And Aisha, where is Aisha? Aisha is there? Aisha is okay. Aisha, a few comments in the history. In the family history, there is a one thing you mentioned, a similar history, family history. Wilson's disease is an entity where there can be involvement of many systems, neurological Wilson, there can be atypical manifestations in the other systems are already mentioned, hemolytic anemia, there can be multi-system problems. They can land up in psychiatric lunatic asylum, one family member was diagnosed by a psychiatrist. Another family member went for the hematologist. Another member for the neurologist. So we need to consider that because it need not always be similar history. So the pedigree chart construction, you need to include the entire range of the Wilson rather than including the two things, jaundice, hepatic failure, and hematemesis only. So other things also need to be considered when you construct the pedigree chart and this thing. In the examination, I don't know, is it directly going to the GI? Always mention the upper GI. In the respiratory also upper GI followed by lower GI. In the examination, the last part, just mention the genitals and hernia orifice also for the completion sake. Always at the end examination, you may miss all these things. The sir has beautifully narrated, describe the way you describe the flow of the umbilical, the distended veins. Most important is above the umbilicus flow going upwards and below the umbilicus flow going downwards. That's specifically to be checked because a flow upwards below the umbilicus, a flow downwards above the umbilicus, you're not dealing with a portal hypertension. It is a SVC or IVC obsession according to this thing. So that the direction also is important. Sir beautifully mentioned the other possibility of hematological disorder, hemolysis, because unusual pallor. So always you'll consider pallor due to GI bleeds or blood loss. But any episodic unusual pallor which cannot be explained by an acute bleed, always consider hemolytic association. And one system which you need to consider in this context is the renal system, because that can involve the tubular interstitial. There is one entity which can involve tubular interstitial and one drug which you are using, D-penicillamine also. So there is a possibility of a renal problem. This case is so typical, there is no need for any other differential diagnosis, but this confusion comes when the features are not typical because the K-ring is present only in 80%, only 20% of the pure GI situations. Neuro Wilson, it is 100%. In a hepatic Wilson, it may not be there always. So it may not be, the family history may not be typical. The K-ring may not be there. So in those situations, it will be more trouble. Sir, you mentioned always at the end, the flapping tremor. So the general examination, we need to include that those things, hepatic failure features like the flapping tremor situation, the classical flapping tremor, the wing beating tremor, and you should be making them right or draw these things. That is the indicator of the hepatic encephalopathy. Thank you, sir, for the wonderful class.
Thank you so much.
Thank you, sir, for those comments. So I think it's 9:30. If anyone else wants to make a comment, please feel
So
free
the
to
verdict is that what is the
unmute and make
verdict
a
of the
comment.
presentation? The verdict of presentation is that Aisha has passed the examination with flying colors. Please give her a big hand.
Congratulations, Aisha.
Thank you, sir.
So thank you very much, Riyaz sir and Aisha, for that wonderful presentation. We had 191 participants, delegates attending our presentation at a point of time. So once again, thank you all on behalf of IAP Kozhikode. We'll be back again next week with the PG teaching program, and last week of next session on pediatric endocrinology. We'll be on behalf of IAP Kozhikode, I thank everyone for a wonderful one. Thank you.
Kelko.
ഇപ്പൊ കേൾക്കാം sir, ഇപ്പൊ കേൾക്കാം.
Darli, where is your PG? Vishnu, he was very good.
Actually, he's having cardiology posting. I don't know whether he has joined or not.
I see.
He's doing well, sir.
Okay, it was very good. It was very good. Last
Yeah.
time he wasn't there.
Yes, yes. I'll convey your regards, sir.
Please do, please do. That means you are all very good teachers, Kottayam Medical College. Yes,
Yes, sir.
because Purush is one of the best teachers. All are good teachers. Yeah. Okay.
Thank you very much, sir.
Purush, your PG is there? Purush's PG is.
End, sir. പറഞ്ഞിട്ടുണ്ടായിരുന്നു already conveyed. So they must be the I didn't see. ഞാൻ നോക്കിയില്ല, ഞാൻ ക്ലാസ് അറ്റൻഡ് ചെയ്യായിരുന്നു.
കുറെ പേരുണ്ടായിരുന്നു പക്ഷെ പോയെന്ന് തോന്നുന്നു.
ടോട്ടൽ 190 മേലെ ഉണ്ടായിരുന്നു സർ.
191 ഉണ്ടായിരുന്നു സർ നമുക്ക് കഴിയുന്നത് വരെ.
TVR, thank you so much.
Sir,
TVR.
sir, sir,
Sir.
as usual. Excellent sessions.
Thank you, thank you.
എപ്പോഴും ആ സാർ എക്സ്പ്ലെയിൻ ചെയ്യുന്ന ആ രീതി പോർട്ടൽ പൊട്ടൻഷ്യൽ ഡയലേറ്റഡ് വെയിൻസ് വരുന്നതും അട്രോഫി ഓഫ് റൈറ്റ് ലോബ് വരുന്നതും ചിലപ്പോഴത് ടെക്സ്റ്റ് വായിച്ചിട്ട് മനസ്സിലാവില്ല. സാർ എക്സ്പ്ലെയിൻ ചെയ്തപ്പോൾ നൈസ്.
ഇത് വീഡിയോ റെക്കോർഡിംഗ് ഉണ്ടല്ലോ അല്ലെ?
ഉണ്ട് മാഡം, ഉണ്ട് മാഡം. ഇത് നമ്മുടെ IAP കേരളയുടെ യൂട്യൂബ് ചാനലിൽ വിൽ ബി upon the YouTube channel soon. താങ്ക് യു മാഡം. ക്ലോസ് ചെയ്യാലോ അല്ലേ സർ അങ്ങനെയാണെങ്കിൽ?
Thank you so much.
Thank you, sir.
താങ്ക് യു.
Thank you.
Good night, sir.
Vishnu,
ബൈ ബൈ.
TVR.